And with that, we want to move next with our agenda because we actually had an exercise fire of our own yesterday. Was it yesterday? What's today? Thursday. Yeah. And we want to hear how that went. We're gonna pull up some of our coalition members, Casey Shuley, Eric Abner, and Daryl Ruby, and they're gonna give us some insight into our regional exercise yesterday. And I guess maybe real quick, how many players do we have in the room here that actually participated in the exercise yesterday? Nice, great. Well, let's hear about it.
I do like the goats. I'm kind of partial to them now. So we did an exercise yesterday. This was our evacuation situational awareness exercise. This is the third one we've done over the course of 2017, 2018. We've talked about the two previous ones throughout the year at these meetings, and we've been sending out communications over it. So this is the third iteration of that exercise. So we switched up the scenario a little bit for this iteration. We had in the previous events or previous exercises, we based our scenarios around a winter storm event. This one was very different. Since it was centrally focused in Spokane, we decided to make it a fire scenario, specifically a single facility fire affecting Sacred Heart. So our largest hospital in the region needed to evacuate, which created a surge of 260 patients that needed to be placed outside of their facility. And our objectives were very similar to the two previous exercises. They were focused on patient placement coordination, patient transportation coordination, and situational awareness. Now, the difference between this exercise and the previous two is we put some pretty hard time metrics on there. So we decided to see how far we could get with all of these objectives within a 90-minute window. All right, so now I'm going to pass it over to Erica to talk about Deaconess. Oh, okay.
Yeah, so we were going to start with Erica, but we figured we'd just kind of start from the evacuating hospital's perspective first, and then Erica can cover some of the key points for her, and we can maybe bounce back and forth a little bit. So I'll tell you, for me, it was a great learning. I've done an awful lot of exercises, but admittedly, and I think the people that were involved with exercise design saw this with me through the design of this exercise. I struggled with this one a lot, just because I was fighting the scenario, and I know not to do that, but I did fight the scenario because it was very narrowly focused. But the really good thing that I heard from Dr. Weil that it gives me great consolation, and that is, and this isn't the best plan, but I'm very confident that at time of event, our organization and more importantly, our community is going to come together. And even though we haven't planned and prepared for everything, we're going to figure things out and get things done. And that's really because we've got some great relationships. And a lot of that starts with the Healthcare Coalition and some of the other partners that we have. So I really appreciated that perspective. It gives me a lot of consolation because after the exercise yesterday, we learned an awful lot. The collaboration in advance was amazing. Typically for me, I often say, the learning is in the design or the planning of the exercise. There's a great Eisenhower quote that goes back, plans are nothing, planning is everything. It's kind of that design process. That was certainly reiterated in this exercise. But some of the key highlights, having just done it yesterday, so it was 260 patients. The part of the scenario that I didn't really like was, we're a very large facility. We're the higher trauma level in the area, so we've got tremendous capability. And the reality is, if we had to evacuate the main tower, or gosh, if we were in the middle of an area like a wildland fire, which we're not, thankfully, but, we're going to keep a lot of patients inside of the facility because the thing we always try to keep in mind is what's in the best interest of the patient. That's really got to be the overriding thing in healthcare. And that's one of the things that kind of drew me to healthcare was kind of that mantra. But in this exercise, we were going to take everybody out. And so that was kind of the part of the scenario that I fought. So we evacuated floor 5 through 9. We had a fairly high census yesterday. We were just about 600 patients, a little bit shy of that for the main tower. The 260 number, kind of based on the fire we had, was floor 5 through 9. Kind of a late change in the exercise was we moved up away from the higher acuity patients. I kind of, on the original design of the exercise, really wanted to overstress us and our planning and figure out what would do with our ICU and CICU and PICU patients and things like that. Kind of a last minute change. We decided to move up and, leave that one for another day. But the other learning really good for us was, and I meant to ask this question, we can maybe talk about it later, was, the unified command with fire and EMS, our EMS partner for the county, AMR, was really beneficial. So we were fortunate in a workshop and in some of the planning to get together, and our fire chief for the community and some of our leaders in the EMS community came together. And so we had a really nice, really quick overview yesterday, which really wasn't part of the exercise objectives per se, but it was a great learning on basic ICS and why we all need to be speaking the same language and common terminology and some of this stuff that, I think everybody, we say, are we NIMS compliant? Of course we're NIMS compliant. I'll ask, are we NIMS compliant? No, we're not NIMS compliant in the hospitals. And with some of our healthcare partners, we've got a long ways to go. We've got a lot of training to do. So the learning for us was, it was really beneficial to get together, have that discussion. Reminded me that there's a lot more work to be done, but it was a really good lesson that we learned there. The one other thing I wanted to touch on that, we really didn't, again, it wasn't an objective of the exercise, but we had a lot of discussion around, and that was patient tracking. And that's, it's a regulatory requirement. It's something that we have to do. We struggled with, we got the census okay. We were able to grab the census pretty quickly, although we realized that we don't have the most efficient forms to do that in a hurry, in a fire, in an event that, is right now kind of like the scenario we just heard. And thankfully, I believe under those, crisis standards and disaster scenarios, most of that does go out the window. Love the idea of taking pictures with the phone. I think somebody had mentioned that ahead of time, and appreciated hearing that was a just-in-time idea that comes around and is a really good one. But so patient tracking, the ability to quickly gather that census, and then get the information that was needed to the other piece that we exercised and that Erica's going to talk a little bit about is, we were using our Disaster Medical Coordination Center, the DMCC for us locally, to do patient placement, and then work with EMS partners for identification of transportation resources. So there's lots of, pearls of learning through the process on how we need to do that better, and I think Erica will touch on that a little bit. So overall, really good lesson. I loved having the skilled nursing facilities involved, some of our alternate, non-hospital partners. We skipped over many of the really important details about physicians accepting patients and some of those other things, and I think we'll get to that. We talked a little bit about pharmaceuticals and, drugs and how we're going to get those, especially in the middle of the night when we have less staff. And I'm sure you guys, you touched on that a little bit. So lots of little things to learn from the exercise, and we can continue to build on. So very, very good experience overall. Just identified that we've still got a little bit of work to do.
Okay, first of all, I do want to touch base because Deaconess did kind of have to play two parts in this because we were also a receiving facility for some of these evacuating patients. So just one thing to touch on from that perspective as a receiving facility, this was actually the first time that we ever used our surge tool to be able to look and see, okay, this is how many beds we have, but how high can we go? And so we actually used that when we contributed how many, the number of patients that we could receive, and helped us take a lot more off of their hands. Some of the things that went well on behalf of the Disaster Medical Coordination Center, we actually had 4 people in there running it, which we found to be needed. I was, kind of controlling things, controlling our phone conference call that we had. I had one of my supervisors who was in the command center operating WATRAC sending out the alert. documenting everything in the command center that was going on. Our EMS liaison, David, was responsible for making calls, being in touch with facilities that weren't yet on WATRAC, and then I had another supervisor there to do other duties. So it was really nice to see the full force of people that we needed to operate that and have them know how to do that. I want to second what Daryl said about participation. I know that this was a central region exercise, but it really ended up being a full regional exercise. The participation for me was probably one of the most exciting parts because, you know, as we built our DMCC process and we've worked on continuous process improvement, as we started exercising maybe in early 2017, you know, we just start out with maybe a few hospitals. And yesterday, it was so amazing to see how much that participation has grown, how many more facilities now have training and use of WATRAC. It was so exciting for me to have skilled nursing facilities and care centers be able to provide us with receiving capability numbers, because in all honesty, they probably took the majority of the medical patients from Sacred Heart. So happy to have them participate. Documentation, I know Daryl had mentioned that we, didn't have the tools. This first time we've really done a big evacuation exercise, and so yesterday morning before the exercise, I thought, okay, what do I need to be able to document information so that we have accurate documentation? I did create a couple tools. They're just basic tools, but made an evacuation list so that when I was talking to Sacred Heart to get specific information on the patients, I was able to gather how many patients they had, not just the number of patients, but their level of care, any specific care needs. And Sacred Heart was also great. I thought when I talked to Laura, I believe, from Sacred Heart, and she gave me the numbers and patient information, it was great to be able to get information on, do these patients have O2? Do they have drips? Are they isolation? It was especially imperative with the critical care patients, so was able to easily document that. I also created a sheet early yesterday morning just called the facilities capabilities list, and I was able to document all the facilities that were participating and get an exact number of how many patients in each level of care that they could receive. And I think that helped contribute to us having a pretty accurate. We were pretty close on how many patients between Sacred Heart and the DMCC on the placement destination. I think that we had 4 patients that there was a discrepancy on, and that's just because we decided at one point during the exercise that they needed to go elsewhere, and I don't think any of us wrote that down. Another positive thing from that was our decision to use a conference bridge call. And I want to thank Daryl for that, because it's something that he was really pushing, and I'm glad we did it. It's not part of our normal process, but we're finding it to be very, very valuable. We were able to get on a bridge call, get all participating agencies, receiving facilities, and Sacred Heart on the line, communicate situational awareness, do a roll call, find out who could take what, take a quick pause, while we decided where they're going to go, get back on the line, and say where the patients were going to go. I think one of the opportunities with the conference bridge is, I think we will continue to use that in the future, but we do need to figure out the timing. When is the best time to get people on the line? And I think from a DMCC perspective, just maybe providing better guidelines and expectations at the beginning of the call, because I know, we would get information and I would tell everybody stand by while we were doing our part finding beds, but then you'd have people calling in on standby time thinking nobody was there. So I think we just need, we'll fine tune it and we'll figure out how to best use it. Let's see here, look down my list. Some of the opportunities, probably the biggest opportunity is updating bed status in WATRAC. Facilities normally, I don't know how all facilities do it, but it's expected that people routinely update their bed status in WATRAC, whether it be daily. At some hospitals it's every shift, but I think we also need to remind those that we work with to update it when you get an alert too, because in looking at they got me this information after the alert, we only had one hospital that updated within 5 minutes, one hospital that updated within 10 minutes, 2 within 30 minutes, 2 within 1 hour, and 1 within 2 hours. And I think it's just imperative to remember that information is crucial. When we do have an alert, we're needing to place patients, we do need that information. And I think that led to the reason why we didn't place critical care patients first. I was asked that by 2 people, why do you start with medical patients and telemetry patients? actually the information we received on receiving capability, first and foremost out of the gate was from our skilled nursing facilities and our care centers. And they were able to say, I can take 20 medical patients, 25. I was told that maybe I should have placed the critical care patients first, but if I would have waited to do that, there wouldn't have been any movement. And I thought, you know what, I have places to send some of these patients. I'm going to get things moving for Sacred Heart so we can start getting patients moving. I think the one thing that we could do better, this was our first time doing this, and this is the last thing, was, Sacred Heart was great to provide information on isolation, O2 drips, and I think when we were looking, we had a specific time frame to place these patients. When we were looking at communicating to patients, just basically stating how many medical patients can you take or how many critical care, we didn't really, we forgot to communicate how many of these are isolation. That is stuff that people would need to know. But I do want to say, within the time frame that we were given, we were able to place 224 out of the 229 patients. We got to the point where we had 4 critical care patients left when, the timer done and, we were done with the exercise, and at that point we were looking to have to, look outside the facility for placement. So I think, Daryl, would you agree that's a lot higher number than we thought we were going to achieve in that 90-minute time frame? So twice as many. Yeah, I know, we should have bet. But no, so anyways, that's kind of how it was from a DMCC and Deaconess perspective. So does anybody have any questions for either of us? Oh, yeah.
Yeah, so we had AMR leading that as transportation coordinator, kind of under unified command. I mentioned earlier we did that. They were working with dispatch and had an awful lot of resources identified. Kootenai County sent over a lot of EMS resources. We had lots of buses. They were reaching out to STA. And I'm not sure if we're ever going to know if we actually had a transportation resource for every patient, because I'm not confident that we tracked that as well as we need to. But I was really impressed with how many transportation resources they were able to get. And, one comment I'd make on kind of the evacuation order, our plan, which in all of the hospitals I support, I don't think is well understood, and I really didn't understand it until we were planning for this exercise, is to go from the lowest acuity to the highest acuity. And AMR, our EMS provider in the area, really kind of confirmed that, yeah, that's really the right order to go. And you can, get the majority of your patients out. And certainly if you've got some higher acuity patients that just happen to show up at the staging area, the ambulances that they had lined up, and I think initially they had 7 initially, and then there was like 14, and I believe those were all real numbers. There was quite a bit of, business happening in Spokane County yesterday, so they were kind of tied up, and we let that play out in real time. But it was good coordination with the EMS resources, and that is kind of the plan that we have in place, is to go lowest acuity to highest acuity. I do like the plan or the strategy of, how many patients can you take? Which ones are we going to get? You're going to get them all. Maybe that's what we should just, that's right. As far as to the various facilities? Yeah, so the question was, the distance to travel. So one of the things we did in preparation was dispatch did some CAD modeling from Sacred Heart to all the area hospitals, and I think about 5 or 7 of the skilled nursing facilities. And that's the part we didn't really utilize, but it was really nice to kind of see that, because certainly if, if a patient's going to travel from Sacred Heart to Kootenai County, that EMS resource is going to be out of commission for a period of time. We had some good discussions in the exercise around, should we send some critical care patients up to Newport? And, the decision was made, no, that's too long to tie up the EMS resources. So again, some good discussions we had during the exercise. Yes.
Just a couple comments. First, your comment was, we would never lose the entire 600-bed level 1 or level 2 trauma center that we have here. And it's never going to happen until it happens.
I don't think I said that, did I? Yeah, maybe I did. knock on wood.
Don't forget private vehicles, right, for little kids especially. And then the other comment I was gonna make was, Eric, was about your comment about the phone calls, which are probably really good for that first hour. One of the traps that we got into was, you know, okay, we're gonna have a phone update at 8 a.m. and then we're gonna go around our whole system and hear from everybody, and that takes 55 minutes. Okay, next update is scheduled for 9 a.m. And then you go, you know, so the first day I had to say, stop, like, we need to get work done around here. So, I mean, it's really good at that earlier point, but you need to give some room to actually, execute what your plans are.
Yeah, so I'll try to summarize that real quick, and then Erica might have a comment. So for those listening online, Dr. Well was just saying, you know, never expect that it can't happen in your facility. Very good advice, coming from your presentation. Thank you. And the other was, yeah, private vehicles, thank you. And we did discuss that briefly. Certainly that would be an option, but in our exercise, we did have enough alternate EMS resources, paratransit and things like that, although there's certainly some opportunity there. But yeah, very, very good realization that private vehicles might be needed at certain times. Oh, yeah, thank you. And then the phone calls, he was making a comment that, you know, you can get into this vicious cycle of having updates every hour, and, you know, the 8 a.m. briefing lasts 55 minutes, and then you've got 5 minutes to get ready for the next one. And so really kind of schedule that out. Actually, I wanted to ask some other questions from your situation, because it certainly didn't allow for kind of a normal planning strategy and tactics to be done. I appreciated what you said about kind of the flat planning and bring all ideas, and you'll make the decision, and, you know, decisions are those that are made, so.
And I think with the conference bridge call, this was kind of, I mean, we tested it out in April. So I think we really need to figure out, you know, how are we going to use that call? What's our objectives in using that call? I think yesterday we discussed, let's just have one phone call, get everything done, you know, but some of the things we need to evaluate is the timing of that call. How long do we give people to gather the information that's expected of them so that we can make that phone call more valuable? Because the phone call was it was a long phone call. We just had everybody stay on there. I mean, it was a long phone call. And so I think it was really long, but just, I think from our perspective and knowing that it's something we want to move forward with, now we can actually start planning on how we want to utilize it and how it's going to be effective and valuable for everybody, so.
All right, I know we have one more presentation after us, so I just want to talk about next steps real quick. We have an after-action review on June 11th. We're going to go through the exercise in a little more detail and shake out some of the areas for improvement and strengths that we want to move forward with. From that, we'll develop our after-action report that will be distributed regionally so everybody can see the official outcomes of the exercise. And then we'll talk about next steps and moving forward for next year's exercise planning efforts. I just want to say thank you to everybody who participated in the exercise and on the planning team. Really, a lot of work went into the planning efforts of this exercise. In reality, it only took about 2.5 hours to do, and it looked fairly simple from the outside looking in, but that's because of a lot of effort went into the planning ahead of time. So, thank you.